Hi, my name is Clinical Planus and you're watching the video on mapping suppression. So far we've learned about how to confirm the presence or absence of a suppression scotoma, and using tests like Worsfold lights or Baggallini striated glasses, we know whether a patient has right suppression, left suppression or alternating suppression. In this video we're going to talk about how do we go about measuring the length of that suppression scotoma. We can use either prisms or the synoptophore. In this video, we'll be focusing just on prisms. Later on, we'll talk about the synoptophore and how to map suppression scotoma using the synoptophore. But in the past, we've also learned that the suppression scotoma is usually between the fovea and the CIP. However, you need to consider that patient suppression scotomas can alter. With time, some patients can anti-suppress, so they can lose part of their suppression scotoma. Also, if you've had a patient with exotropia who's been overcorrected with surgery to an esotropia, their suppression scotoma will change. It will be temporal to start off with, and then it will extend over onto nasal retina as they become esotropic, if that surgery was performed when the individual was young enough to develop suppression. So, in which instances do we actually go to the effort of measuring or mapping the suppression scotoma? It's when a patient is about to have surgery and we're interested in knowing where are the areas of single vision. Not binocular single vision, just what are the areas where the patient sees single, so what is the area of suppression. Because what we want to do is post-operatively ensure we don't give the patient double vision. And if we move the CIP outside of the suppression scotoma, and the patient has no potential for binocular functions, they will experience diplopia, and diplopia that they can't fuse. So it's going to be very annoying for your patient. So it's important that we map that suppression scotoma and we guide the surgeon as to the amount of surgery that they need to do. So as an example, if we map the suppression scotoma and this patient has an exotropia and we find that it is between the CIP and the fovea, but that nasal retina is not suppressed at all, we can tell the surgeon that this patient needs to be either fully corrected, which means correct the entire amount of the deviation, so if it's 35, you do 35, or they can safely be undercorrected. They won't experience double vision. But if you make them esotropic, nasal retina is not suppressed, they will have diplopia post-operatively. Now, this is only a concern in older children and beyond, or adults and so forth. Younger children, if you operate on a 3-year-old and you overcorrect them into that esotropia, they're just going to suppress. Older children and adults clearly won't suppress, and therefore you're going to have this diplopia that you're going to have to deal with and go back in and operate or find other alternatives in giving that patient single vision. Okay, so essentially in mapping out a suppression scotoma, we're doing a post-op diplopia test, and post-op meaning post-operative. And in using prisms, what we'll do is we'll use base out and base in prisms for horizontal deviations and base up, base down for vertical. If a patient has a combination of horizontal and vertical, you can do the vertical separately and then you'll do the horizontal separately. So let's have a look at the example over here where we have a left esotropia, and what we can see here is the suppression scotoma extends from fovea to CIP and beyond CIP. And what this is telling me is that this patient must have probably had a larger esotropia in the past and most probably was operated on, now has a smaller esotropia. Otherwise, really you shouldn't have a suppression scotoma beyond the CIP. Okay, so we put a base out prism and what we see is that the light bends towards the base, and the patient should have single vision at this point because they're within the suppression scotoma. So as the base out prism comes this way or sends the light rays this way, there will be single vision all the way to fovea, and then just when we get past fovea the patient will experience diplopia. So let's say that's a 35 diopter ET. There should be single vision up to 35 diopters, and then on the 40th diopter, or the next prism, which is 40 diopters, the patient will experience diplopia. We can then rotate the prism in the other direction, in which case we'll get the light rays moving in the other direction as well, and we'll find that it's single vision here until we reach the edge of that, or until we go past the end of the suppression scotoma, in which case the patient will experience diplopia. So in doing that, we can map that suppression scotoma. It will give us information around the surgery, which is around here at the fovea, because obviously the surgeon is going to want to move towards fovea and make the eye straight. And when we're going in the other direction up here, we're just gaining information about the history of this suppression scotoma. If we find that there is a suppression beyond the CIP, it's an indication that this used to be larger in the past. In terms of recording, we indicate that we've performed a post-op diplopia test, and you will document descriptively, essentially, where the patient had single and when there was diplopia. So here I've indicated the patient's got single from the very first prism to 35 diopters base out, and then diplopia was experienced with the 40 diopter prism and anything above that. Okay, that brings us to the conclusion of this video. Thank you for watching.